Even when the treatment goes as planned, sometimes it doesn't always end up the way we want it to or expect it to. Root canal treatment, tooth number 18 with a 7-year follow-up. I'm Bill Nudera. Welcome to my channel dedicated to clinical endodontic education. Tooth number 18, the lower left 7, was diagnosed with symptomatic irreversible pulpitis and symptomatic apical periodontitis. The radiographic exam showed a large restoration with recurrent caries on the distal in very close proximity to the pulp. And there's a little bit of a widened PDL space. The treatment process went as planned, the pulp was confirmed vital upon access, and all the canals merged into one single portal of exit. There were no complications, no issues with the treatment process. I used a positive pressure irrigation technique and obturated this case with a warm vertical technique with a eugenol-based sealer. I was really happy with this final result, and I advised the patient to return to their restorative dentist for that final restoration. The patient was referred back to me 7 years later as symptoms began to develop again in that same area. The radiographic exam shows a significant loss of bone in the vertical aspect on the mesial area, consistent with the findings of a vertical root fracture. The patient does have a history of nocturnal bruxism, but no fractures or any indicators of that were noted 7 years prior during the original treatment. Looking back at the preoperative periapical, although there is no evidence of a fracture, it is plausible that the fracture may have been present and contributed to the initial symptoms, leading us in the direction of root canal treatment. But when other potential etiological factors are present, like large carious lesions under restorations that are in close proximity to the pulp, things like fracture are a little bit low on our list as primary etiological variables. I think sometimes these relationships happen more often than we think. A patient that's diagnosed with symptomatic irreversible pulpitis and symptomatic apical periodontitis with clear restorative or recurrent caries etiological variables, those overshadow the potential of incipient fractures. But realistically, we may have multiple sources or multiple etiologic issues that can contribute to a single problem. And over time, the other problems sometimes can present themselves in those classic radiographic presentations, as we see here. Another interesting thing I see here at 7 years is what's happening around the apex. The post-operative image shows sealer displacement into a lot of nice apical anatomy. But 7 years later, where is it? It's all washed out. Well, the answer is it resorbed. And it's common for eugenol and resin-based sealers to resorb over time. But my concern is how much of this resorption was limited to the external surface of the root and how much of it percolated back in that root canal system and washed out my seal in the apical area. Does it matter if the sealer gets washed out in the apical area externally? Probably not. Does it matter if apical percolation causes the sealer to be resorbed internally? It might. I'm not certain, but what I am certain about is I don't see as much of this effect when I use a bioceramic sealer as opposed to the resin-based or eugenol-based sealers. The coronal plane on the cone beam scan shows some damage to the buccal cortical plate, but the real damage is visible in that sagittal plane. That classic vertical bone loss pattern on the mesial is consistent with a vertical root fracture. The long-term prognosis here is completely unfavorable, and the only option we have here moving forward is extraction. The plan moving forward was to remove this tooth, apply a socket preservation graft, and plan for implant replacement in 4 to 6 months down the road. Following proper anesthesia, I made a very controlled intersulcular incision to address the soft tissue there on the buccal and reflected a small flap. In my hands, I like taking this step prior to elevation because if I'm planning to replace this tooth with an implant, I want to try to have as much control over that gingival tissue as possible. If I don't reflect a flap and I get in there with my elevators, there's a significant risk that I'm going to crush the tissues and create an unfavorable result. We do the best we can to extract these teeth atraumatically so we don't damage the cortical plates. And once we take this tooth out, we can clearly see the confirmation of that vertical root fracture on the mesial root complex. If we go back to the cone beam scan, now that we know where the fracture is visually, the question is can we see it on the cone beam? Because with a fracture this large, we would expect to see something. But the reality is it's difficult to visualize these fractures on the scan. So the judgments regarding the diagnosis of a vertical root fracture are based on bone loss patterns, mostly, as opposed to seeing the fracture itself. Once the tooth is removed, you irrigate the socket, you curette the socket, remove any tissue that may be in there until you're down to nice solid bone, and you try to initiate bleeding in the socket. Once that bleeding is initiated and I'm happy with it, I apply some DFDB allograft in that site, and I pack it to the level of the crestal bone. A resorbable collagen membrane is tucked under the buccal and the lingual. I used 5/0 PTFE sutures to secure the membrane and graft in place. And this is what the radiographic appearance of that graft looks like. So we're about 4 to 6 months away from actually finding out what the bone is going to look like or how it's going to heal in order to plan for that next step of implant replacement. So stay tuned. I'll be sure to post updates as we move forward. I hope you've enjoyed this video today, and I encourage you to hit that subscribe button so you can stay up to date with all of my new videos. I'm Bill Nudera. Thanks for watching.